Our third topic today from the posterior segment complications of cataract surgery, which is very important also, is the pseudophakic retinal detachment. Pseudophakic retinal detachment, the retinal detachment remains one of the most serious complications of cataract surgery. It has been estimated that up to 40% of the patients referred to vitreoretinal surgeon for retinal detachment is after cataract surgery. In the past few years, there has been continuous improvement in the surgical procedure and the machines and IOLs for the cataract extraction. This has led to increase in the success rate of the procedure and in the popularity of the surgery. The incidence of retinal detachment after cataract surgery has been estimated to range between 0.6 and 1.7% during the first post-operative year, in comparison to overall incidence of retinal detachment in the whole population of the world, which range between 0.0061% and 0.0179% per year. With the duration of follow-up, there is still excess risk of 5.5 folds compared with unoperated eyes 10 years after cataract surgery. It has been estimated that 94% of the retinal detachments that occur in the first year after surgery are attributable to cataract surgery. But this proportion gradually reduces during the subsequent years after the first year. What is the incidence? There is three types of cataract surgery. There is the intracapsular cataract extraction, which is now obsolete. There is extracapsular cataract extraction, always near to be obsolete also, and phacoemulsification. After the intracapsular cataract extraction, the incidence was very high. It's ranged around to be between 1 to 8.1%. And after this, estimated after a range of follow-up between 1 week and 22 years. It's a very big study. And after the extracapsular cataract extraction, it's less than the intracapsular, but still high. The incidence of retinal detachment is from between 0% and 7.5% after a range of follow-up between 4 months and 18 years. And what's the incidence after phacoemulsification? The reported incidence of retinal detachment after phacoemulsification varies widely, with a range from 0% to 3.6% and an average of 0.7%. The variation may reflect the differences in complication rates and duration of follow-up between studies. Very important issue. How about the clear lens extraction? There is a very big debate between the surgeons regarding the clear lens extraction. Removal of the crystalline lens in highly myopic patients remain a controversial surgical procedure in ophthalmology. This is at least in part due to the fact that the myopic eyes have a higher incidence of retinal detachment than the non-myopic eyes without surgery. So, retinal breaks, giant retinal tears, and retinal detachment, there is a highly incidence to happen after cataract surgery in a myopic patient than the non-myopic eyes. And it's the range from 0% to 8.1% in uneventful surgery. What is the risk factors for pseudophakic retinal detachment? There is a pre-operative risk factors. Sex is not clear if it's affected or not. The age. A younger patient seems to have a higher incidence of retinal detachment after cataract surgery than the older people. The high myopic patients, the studies stated that the risk of pseudophakic retinal detachment increased many times in the myopic patients. The intraoperative risk factors, the most important one, as all of us know, the vitreous loss. Vitreous loss at the time of cataract surgery appears to increase the incidence of retinal detachment following cataract surgery. Some studies found that pseudophakic retinal detachment increased 5-folds in cases complicated with vitreous loss. How about the posterior capsulectomy? Posterior capsulectomy, planned or not planned, the disruption of the posterior capsule appears to increase the risk of pseudophakic retinal detachment after cataract surgery. Some studies, the patient who had ruptured posterior capsule had 13-fold excess risk for pseudophakic retinal detachment. Planned posterior capsulotomy appears to increase the risk of retinal detachment from 2 to 2.5 times after cataract surgery. What's the post-operative risk factors? Yeah, posterior capsulotomy increase the risk of pseudophakic retinal detachment 4 times and vitreous incarceration in the wound. What is the pathogenesis? Vitreous changes following cataract surgery are probably responsible for the increased incidence of pseudophakic retinal detachment. The most important change in the vitreous is the posterior vitreous detachment, which is its rate is higher after cataract surgery. It remains unknown why there is an increased incidence of posterior vitreous detachment after cataract surgery. It's possible that anterior movement of the vitreous, which can occur after the lens has been removed, could play a role in the development of PVD. Forward movement of the vitreous may also produce dynamic traction and lead to small holes or tears in the peripheral retina. Clinical findings. Patients usually present to the ophthalmologist with the symptoms like floaters, decreased visual acuity, flashes of light, and visual field effect. On examination, there is some difficulty to examine a patient with a pseudophakic retinal detachment. What is these difficulties? Sometimes small pupil, vitreous opacities. There is also opacification of the anterior or posterior lens capsule. The presence of IOL also, it's challenging for a good examination, especially for the periphery. Due to the poor visualization of the retina, the retinal breaks are not found in almost from 4.8% to 75% of pseudophakic retinal detachment. You can examine the patient very well and they cannot recognize the tears. Pseudophakic retinal detachment have a predominance of small horseshoe tears, often located anterior to the equator, near to the ora serrata, usually in the superior temporal quadrant more than the other quadrants. Macula is in highly percent of the cases they come to the clinic with a macula of retinal detachment. What's our management for a case of pseudophakic retinal detachment? The first line of treatment is a scleral buckling. Scleral buckling, although it has a high anatomical success rates, but the results with the pseudophakic retinal detachment is still very much less than its result with aphakic retinal detachment. It cannot be used also in a patient with poor prognosis and the patient with proliferative vitreoretinopathy. The higher incidence of recurrence than vitrectomy alone or vitrectomy with a scleral buckling. Pneumatic retinopexy, it's only in a few or very small percent of cases. Pneumatic retinopexy was first introduced in the mid-80s, recommended in a management of retinal detachment caused by single break, not larger than 1 clock hour and located within the superior 8 hours of the ocular fundus, or by a group of small retinal breaks within 1 clock hour in the absence of PVR and glaucoma. Later, the cases with multiple retinal breaks located more than 30 degrees apart were also treated with this technique. Perfluoropropane, this is a C3F8, and sulfur hexafluoride SF6 are the most commonly used gases for the pneumatic retinopexy, but it's used, as we told before, in a very selected cases. There is a high incidence of failure and recurrence. There is a better result in phakic also, same the buckle, than the pseudophakic eyes. The third thing, and this is widely used now, most of the people, due to the advancement of the machines and the visualization system and all this, shift to primary pars plana vitrectomy with or without scleral buckling according to the case. What is the advantage of pars plana vitrectomy over scleral buckling technique alone? There is a possibility of identification of retinal breaks by using internal such with the indirect viewing system, scleral indentation, thus retinal breaks undetectable by careful clinical examination you can determine inside the surgery. What is the steps of vitrectomy? Is induction of posterior vitreous separation, then good vitrectomy with shaving of the vitreous base is a very important step in the vitrectomy for retinal detachment to make a good shaving. Then you identify the tears and mark the tears with the endodiathermy. Then according to the case and according to some surgeons prefer to do air fluid exchange through a posterior drainage retinotomy. The others prefer to do perfluorocarbon and drain the fluid from the original tear. And then you can do air fluid exchange or PFC air exchange. Then we will do good laser for the tears, plus or minus 360-degree laser brush. There is some surgeons, especially in pseudophakic retinal detachment, prefer to do 360-degree because, as we told before, there is tendency in pseudophakic retinal detachment to have a very small peripheral tears. Even with a good examination, sometimes some tears you cannot recognize, so 360-degree decrease, in my opinion, in the pseudophakic, especially pseudophakic retinal detachment, decrease the incidence of recurrence. And then the tamponade. The tamponade, either gas or silicone oil. This also according to what do you prefer and according to the case. What's in the case? The gas in the form of SF6 or C3F8 and silicone oil. We will see this video is the removal of intraocular contact lens together with phacoemulsification and the repair of retinal detachment. Now we are using 23 valved trocar, and now we are inserting the trocars. This patient was a very high myope. Even his IOL calculation is almost minus 10. Now we fix the trocars. Now we will open a corneal incision. As we see, this is the ICL inside, intraocular contact lens. The patient also has a posterior subcapsular cataract and retinal detachment. He is very high myope. Maybe his refraction before implantation of ICL was almost minus 28, 29. Now we inject a halon above and under the lens to protect the cornea. Then I am rotating the lens. Now injecting viscoelastic again. It's a very important step to protect the cornea while you are removing the lens. As we know, it's a very thin, flexible lens, so we can remove it from this corneal wound. Now I am removing it with a lens forceps. As we see, this is the ICL. As all of us know, ICL is a big lens. Even it's very thin, but it's a big from limbus to limbus. Then I am injecting viscoelastic again to make the capsulorhexis and to remove the cataract. The problem now, the pupil is closing. As we will see, just I will start the phaco, the pupil will close. Now removing the epinucleus and the cortical material. You have another options. If you cannot work in the small pupil, you can put a iris retractors. There is many advanced iris retractors which is easy to use. Now I am cleaning the cortex, the remaining cortex. As we see. Now, after we check the infusion, we will start vitrectomy, as we will see. I started first anterior vitrectomy, then I am now starting to remove the posterior hyaloid. As we see, I am stripping the posterior hyaloid now. This is one of the most important part in nearly whole the retinal surgery. As we see, there is multiple tears. There's multiple horseshoe tears. I'm making now core vitrectomy after I remove the posterior hyaloid. As we see, the retina is very mobile. We must clean the vitreous very well, as much as we can. Now we are shaving the vitreous around the wound, around the tears, sorry. Some people prefer to inject perfluorocarbon to make the retina less mobile. But this is according to what your way to work. For me, I used to do without perfluorocarbon. Now we are cleaning the vitreous base and the vitreous around the wounds, as we see. Now I am trying to clean as much as I can, because in some cases, especially the myopic cases, you will find a strong vitreoretinal attachment at one point. Even you cannot pull the vitreous more than from this side, so you can clean as much as you can to release the traction on the wound. I try to be careful not to induce iatrogenic tears and like this, because the retina is mobile. So try to be careful while you are doing vitreous base shaving. Now I am trying to clean as much as I can the vitreous around the tears and the peripheral vitreous. Now we will mark the tears, as we see here with the endodiathermy. It's an important step, because maybe after, if you will do air fluid exchange, you cannot recognize the tear after the retina become flat. Then I will do posterior drainage retinotomy. Also, I try to clean some vitreous again, because still some vitreous, peripheral vitreous, I try to shave as much as I can, which is very important in a retinal detachment only. If you have some case which is not retinal detachment, no need to shave as much as you can. You can shave only little. Now I am implanting the intraocular lens, as I told you, which is its number is very rare, it's -10. Now I am doing air fluid exchange through from the tears and from the drainage retinotomy, as we will see. The retina now is going to be flat. Also, it was difficult in this case that he is very high myope, so the eye is very long, so you cannot reach the retina with the instruments easily. Now we are doing laser around the retinotomy and the tears, as we see now. I did 360-degree laser. Now the retina is totally flat, and I did 360. As I told you before, I prefer in the pseudophakic retinal detachment to do 360-degree laser, because if there is any hidden small hole or a small tear, so it will be covered with the laser. Now we are injecting the silicone. Now, as we see, I removed one valve, and I am injecting the silicone now. Our retina is flat. Then I will remove the trokers and everything is okay. Now we are testing. You must leave the patient with the silicone oil in a slightly low pressure. I am testing the eye now. Everything is good, so I will remove the trokers. What is the home message for the pseudophakic retinal detachment? Careful and good examination for the cataract patient before cataract surgery, especially very careful examination before surgery for the myopic patient, adequate patient counseling following cataract surgery, and patient education about the retinal detachment. And we must tell the patient if at any time after cataract surgery he see flashes, floaters, or any changes in his vision, he must to come direct to his doctor. The decreased manipulation as much as you can during cataract surgery, especially if there is intraoperative complications. Thank you very much.